Dr. Demetrio J, Aguila III, and I am the host of the Direct Care Movement podcast, where we are going to dive into questions of money and medicine and where they intersect. We're going to dig into questions that maybe you've wanted to ask before, but you didn't know who to ask, or maybe you didn't know you were allowed to ask, or you didn't know how to ask. And we're probably going to dig into some questions that you didn't even know you wanted the answers to until you heard them here today. We're going to do that and a whole bunch more. And I'm excited to have with us today Dr. Matthew Abraham. Thank you for joining us, Dr. Abraham.
My pleasure. Good morning.
Good morning. So can you tell us a little bit about yourself? Give us a brief intro so that our audience knows who you are.
Sure. I'm a general surgeon by training. I'm from the Midwest originally, Ohio, and I did my residency and fellowship in Knoxville, Tennessee as a general surgeon and then trauma critical care fellow. After that, I got a job working for one of the largest hospital systems in the country in North Carolina, where I worked for 4 years as a trauma and acute care surgeon. Over that time period, we went through the beginning of the COVID pandemic, and I got quite a healthy dose of hospital corporate medicine. And I had a number of conversations with friends who were direct primary care doctors and got familiar with the Free Market Medical Association. And like you said, I had some questions that had been bouncing around in the back of my mind since medical school, where I'd been told the first day of medical school that the free market simply could not apply to healthcare. And things finally clicked in 2022, and I decided to leave that job and came out here to Idaho to start the Veritas Surgery, which is a direct surgical care group providing direct care surgery in the free market.
Awesome. So what does that look like exactly? You know, when we talk about direct care, I mean, I think a lot of people are really familiar with, or at least a lot of people that are listening to this are familiar with the concept of direct primary care, but they may not be as familiar with how it works in a specialty setting, and particularly for surgeons.
Yeah, obviously you're not going to pay a subscription fee for surgery, but we still preserve the same principles. The key problem with the medical system right now is that the patient's not the payer anymore. The person who's paying is the customer, and they ultimately control the relationship, whether it's visibly by saying you can or can't have that surgery, or invisibly by pressuring how physicians practice, how patients find their physician, how patients pursue care. The entire relationship is going to be shaped by the person who pays. And so the fundamental change is simply making the patient the payer for any medical care. So if you want your gallbladder out, the patient is the one who shops around, knows what it's going to cost, and makes the decision, an informed decision based on that information, whether they want their gallbladder removed or whether they want to proceed with a knee replacement. Practically what that looks like is we list all of our prices on our website. So a hernia is going to set you back $5,500. A total knee or a total hip replacement is $24,500. And so the patient can see that price. They get a chance to talk with their surgeon and know exactly what their options are. If there's options for their surgery, they see the prices for all of those options, and they can make an informed decision with the surgeon about what they want to do. And then some of those patients are paying that full amount out of their own pocket. Some of those patients have assistance from their employer or from a sharing ministry. But ultimately, the patient is still the one who makes that decision with the physician with that information in front of them.
So what you're saying is that the only prior authorization you need is that of the patient.
That's correct.
Yeah, there's no person in some ivory tower 1,000 miles away who's never met the patient and doesn't really care about the patient making decisions about whether or not the patient get the care.
And doesn't know much about the medical situation.
Right. So how did you reach this point where, what was the breaking point where you said, you know what, enough of the old way, we're going to do something different?
Yeah. Like I said, it's an idea that's been bugging me since medical school. Our first day of medical school, we had a class explaining how the American medical system worked, how we got insurance as a result of wage freezes after World War II, and so on. And one of the major points in that lecture was why we can't have a free market medical system, because medicine is too complicated for patients to be informed buyers, and the prices are too obscure and complex to give patients a transparent price up front. And it's not something you can shop around for, all these different reasons. And none of that made sense. And I had always been leaning a little bit more libertarian and small government, and all of the arguments about why we needed Big Brother to control things and provide stability and price controls and a safety net just never quite clicked. But at the same time, medical school and residency is a long process. It's expensive. And by the time I came out, I just needed a job. So like I said, I got a job with a large hospital corporation, and honestly didn't have anything to complain of there. You hear a lot of stories from physicians who were in the system and got so fed up that they were at the point of either quitting medicine or doing something different. And that really wasn't me. I was perfectly happy with my job. My employer was fine to work with, but at the same time, just on principle, that those thoughts were still rankling. And the more I heard about the possibility of doing something else, the more that made sense, because we keep having these conversations about how healthcare is broken and we need to fix it. And none of the other solutions really seem to be making progress or providing real change. And so the idea of fundamentally changing how the financial relationship worked seemed to me at the time like the only real option for making that happen. So then the actual change came about because I was talking, like I said, I have a really good friend who's a direct primary care doctor here in the area. And he was telling me about the challenges he faces, where he's got all these patients who love paying him directly for his services. But then when he needs them to have surgery, his best option is to send them from Idaho here down to Oklahoma, to the Oklahoma Surgery Center. And that's a half day to a day of traveling just to get there for these patients. And was eager to see some more local options come up. So he convinced me that I needed to come out and start that for him. So that was really what the trigger that made me shift.
Sure. So now here you are in Idaho. And I think some of the people who are listening to this podcast are familiar with what Keith Smith has done down in Oklahoma City, a free market surgery center, freestanding, and all they do is free market surgery. But you decided to choose a different approach that still serves those principles, but doesn't look the same as what Keith is doing. Tell us more about that.
Yeah, when we started, we thought that was the way to do it. You have to follow the model that Dr. Smith set. You start your own facility, you own everything, and hire the anesthesiologists and surgeons to do the work there. And that's a great model, but we realized that we needed to tailor that to our local market, our local population. Here in the Northwest, the population is much more spread out. There's a lot smaller population density. Smaller population overall. There's a lot of companies that are interested in that are self-employed or self-insured. There are a lot of self-insured companies, but they're kind of scattered all over the region. And so what we realized after doing some research and planning was that it just didn't make sense to build our own facility and try to centralize everything in one location. So what we've developed is we have really good working relationships with a number of surgery centers around the region. So there's all these ambulatory surgery centers across the country that provide excellent quality, that are certified by independent organizations, provide all the medical research actually shows that you have better outcomes if your surgery can be performed at an outpatient surgery center, lower infection risk, faster return to function, just better outcomes overall, fewer complications. But because of the insurance dynamics, hospital power plays, and so on, increasingly, the entire medical system is a funnel towards hospital-employed surgeons doing procedures in hospitals. And so there's these excellent high-quality surgery centers which are eager for business and are also simultaneously much more affordable. So we've set up these relationships with these surgery centers where they have agreed on a cash price with us. And so we can advertise that cash price combined with our surgeon's fee and the anesthesiologist's fees. So we know exactly what those prices are going to cost up front. The surgeon has an informed conversation with the patient and tells the patient what their options are going to be. And obviously surgery can be complex. There's not always one clear answer for what needs to be done, but a competent surgeon can usually tell with a high degree of accuracy we are either going to do option A or B or C. And so we can tell the patient, those are your three options. Here are the three prices that those are going to cost. And then we have the contract in place with the surgery center and the surgeon and the anesthesiologist where we make sure that that's going to be actually what the patient pays.
Sure. So then the model that you're talking about, obviously requires a market where the surgery centers are amenable to this kind of arrangement.
Hmm.
Um, how did you end up finding those surgery centers that wanted to have that discussion?
It really was more a question of finding surgery centers that were quality, that we trusted and could have a good relationship with. After that, it was easy. They were enthusiastic about what we were presenting, and were eager to have a way to offer those cases to cash patients and not have to rely entirely on the insurance system for their volume.
Okay. And then like let's say I'm Joe Schmo surgeon in, I don't know, Illinois. Or maybe Illinois is not a good example. Let's say Kansas. Okay. Because I get the impression that they're a little bit more open to some of these ideas in Kansas. So I'm Joe Schmo surgeon in Kansas, and I want to build something similar to what you've done.
Mhm.
Um, where do I start?
I think the biggest thing is starting with personal relationships, and that's sort of why the direct care movement is offers some real hope for fixing the healthcare crisis, because that it's the local direct relationships that are going to be the solution. Top down, nationwide programs like Amazon One and Walgreens Care and so on rely too much on giant corporations without any local knowledge or personal relationships. The real solution that we found is when your partners trust you and trust that you're going to pay what you said you're going to pay, it removes a lot of the cost of doing business. So the biggest things that we found helped were demonstrating that we were trustworthy, that we were going to make good on our promises. We weren't here to do a bait and switch, offer one price, and then after the surgery's done, we're going to lower the fee or refuse to pay or something like that. So once a surgery center trusted us that we were going to make good on our promise, they were eager to work with us. And then the other thing is making things easy for your partners. So a lot of the reason that patient shopping around for a cash price has trouble finding quality fees or affordable fees is because the surgery center or the surgeon is trying to cover themselves in case payment doesn't work, in case it takes a long time to collect the money or you don't pay or things like that. And so when we've set up our relationships so that it's almost effortless. We pay the surgery center the fee that we've agreed on within basically 24 hours of the surgery. As soon as they tell us that the surgery actually happened, we send them the money. So there's almost no effort required on their part. They don't have to change their way of doing business significantly, and they don't have to worry about it. So that trust and also simplicity has made it really easy to get them to work with us and have a good working relationship.
So then, if I understand you correctly, you are bundling the prices on the front end for the patient. So instead of having to pay three or four different fees, they're paying one fee, and then you distribute those funds to all the involved parties.
That's right. Yeah. So the patients will only ever receive one bill for our surgery. The surgeon, anesthesia, facility, obviously are all included, but we actually go a little bit beyond that too. So if there's pathology involved, when I do a colonoscopy, for example, the pathology is included in the cost of that colonoscopy. For a hip replacement, when one of our surgeons does a joint replacement, the patient's durable medical equipment, a continuous passive range of motion machine. Our surgeon uses cold compression for DVT prevention. All of that stuff is included in the one bill that the patient is paying us, and that's one of the things that makes this an attractive relationship for our partners and for the patient. We're assuming some of the risk. We're not simply passing on the cost that we're incurring. So sometimes, for example, I'll do a colonoscopy and the pathology will cost several $100s instead of just $50. And so the patient never sees that. The patient still only pays the one fee. So we're assuming some of that risk, and in order to simplify things and make the experience less stressful and less unexpected for the patient.
Sure. So I'm just anticipating some of the questions that some of our listeners might have. And I'm glad you brought up the question about the pathology, because it leads to another question, which I suspect you've already answered, at least implicitly. So let's say, for instance, you're doing an inguinal hernia, which obviously is a pretty straightforward procedure, usually very predictable. But let's say you run into something unexpected, and let's say you've got a bleeder or whatever, and that inguinal hernia, you've just doubled the amount of time you spend in the operating room.
Yep.
Um, it sounds to me like you are still taking on that risk and any potential increase in cost associated with the extra time spent. Is that right?
Yeah, that's right. There's a variety of things that can go wrong in surgery. Anything from, like you said, a minor change in the procedure that's just going to require extra time to address, all the way up to a major complication, a patient having a heart attack or a stroke on the table. And we handle those a little bit differently. So if it's something related to the surgery, especially if it's something that we should have been able to foresee, like a patient having slightly higher risk for bleeding, or you go in to fix one hernia and realize that there's two hernias, that is on the surgeon and on us. If we didn't adequately prepare the patient and tell them what their options were going to be, and then realize that something else was clinically necessary when we get there, that the patient doesn't pay anything additional. The patient pays what they were told to expect. And like I said, any competent surgeon is usually able to predict pretty accurately what's going to come up. So it's that, and that's part of the value of making the patient the consumer. Now it's on the physician and to have that informed discussion with the patient and make sure that they know up front. With the traditional insurance model, the physician ends up being able to bill insurance after the fact for whatever they did. So that subtly introduces this pressure where the physician no longer has to really treat the patient as the informed buyer, because it's insurance that's the buyer who will pay whatever you want. But when the patient is responsible for it, and the patient only pays if you talked to them up front, that introduces this incentive for the surgeon to make a greater effort to ensure that the patient is fully informed going in. So things like that, minor changes, bleeding or finding something else that needed to be addressed at the same time, that's on the surgeon and on us to absorb that additional cost. Sure. Major complications like a stroke, heart attack, something like that, that's not really something we can predict. And we have a conversation with the patient beforehand and clearly explain that to them, that if there's something major and unexpected and different, that will still be your responsibility. Just like if you were driving down the street and had a heart attack, then you're responsible for that, using whatever coverage or assistance you normally would, whether you have catastrophic insurance or a sharing ministry or something else, that would still be covered under those things. So the surgery, anything related to the surgery directly, and anything that we should have reasonably been able to predict, that's on us to cover for the patient.
Sure. So to use an analogy that, maybe will help illustrate this outside of medicine, if I'm a burger flipper at some fast food restaurant and I accidentally drop one of the patties on the floor in the process of making your burger, you don't have to pay for the second patty when you ordered your cheeseburger. You still pay the same amount regardless of how many mistakes I made along the way, because I should have planned for that, right?
Right.
It's different. Like, there's an explosion in the kitchen. That's a different story, like,
we'll figure something else out if the entire burger joint blows up.
Right. Exactly. Okay. So,
Yeah.
so that's,
and actually one way that we've dealt with that, we've even had patients who had a complication after surgery, and had to go back to the ER for that. And because that was something directly related to our procedure, not an unexpected thing, we covered the patient's ER bill and the procedures that they needed there. That's fortunately the good thing is, with surgery, that kind of complication is relatively rare, but that's part of what we do. When we tell the patient that we're going to make sure you pay one price for your procedure, we're gonna take some additional responsibility to cover those unexpected issues that come up.
Sure. So now I know there are some people, some surgeons I've spoken to, particularly cosmetic surgeons, and I've seen some of this migrating into the non-cosmetic space, but they offer, in some cases, they offer as an add-on, or they incorporate routinely into their cost of care, like a catastrophic, one-time insurance plan that covers, the potential for complications. That's done by a third party.
Yeah.
You guys do anything like that, or you just incorporate that into your plan already from the beginning?
Honestly, we looked at it, and what we've realized, that a lot of these things are actually fairly easy to do yourself and cheaper if you do it in-house instead of taking on passing that risk on to somebody else. The main one that we looked at was quite expensive. It would have added 10% to the cost of any procedure that we did without providing significant benefit. For an extra 10% on the total cost, you got 90 days of coverage, but only up to a couple $1,000s of additional cost, and for a fairly limited number of complications. And if it was outside the list complications for that procedure, then it still wouldn't be covered. So it was expensive and didn't help much. And we realized that we could absorb that in-house. Honestly, we've realized the same thing about financing. Some people in the cash space will offer financing options through a third party. And that's a great option, especially for patients who are able to pay but don't have the cash flow to pay up front. They just need 6 months or 12 months or something like that. And what we realized was, again, you're paying 5, 10, 15% of your margin to somebody else to handle the financing, whereas all they're doing is deciding whether the person is trustworthy and then extending them financing terms. And so what we decided to do for the time being is simply make that determination ourselves. We talk to the patient, we get to know them, we discuss where they're at and what they need, and then we extend them terms in-house to pay over an extended period if that's necessary. But it's often turns out that introducing a third party to provide those services is just adding cost without significant benefit to you or the patient.
Sure. So how do you mitigate that risk associated with, spreading those payments out over time?
A lot of it's just good planning, because
is it mainly just a conversation to figure out how trustworthy the person is, or are there more specific things that you do?
No, it's mostly a conversation with the patient. We've gotten to know different kinds of patients and their background and what resources they have available to them, and then it's just evaluating each situation on a case by case basis. So we don't have an official policy or a published financing terms. We just discuss with the patient what they're able to do and what they actually need clinically.
Awesome. So let's shift gears a little bit here. So we spent a lot of time talking about the process of getting a patient to the operating room, doing the surgery itself. Let's talk about your practice specifically. What are the differences that were high priorities for you? What were the things that you wanted to make sure you were doing differently in your practice when you decided to go into free market medicine versus how you had always done them before?
Well, the single biggest difference is the time with the patient. Previously, when I was working for a hospital, we saw a patient every 15 minutes in the surgery clinic, and that was everything from routine follow-ups to preoperative appointments, patients who had an appendectomy and just needed a quick check to make sure they were doing okay, to a patient who had diverticulitis and was planning for a major colon resection. And most of the time that worked out okay. You were able to address most of the patient's concerns, but it often ended up feeling rushed, and the patient had additional questions that weren't able to be answered. And so the single biggest thing that changed now is I routinely spend 45 minutes to an hour with a patient before surgery, answering all of their questions. So our patients all feel like they have more than enough time to talk about everything. I get to talk with them about non-clinical stuff too. So I get to know them as a person, hear more about their social background, what things are important to them, instead of simply seeing them as a medical problem to solve with my traditional set of tools. And then the other thing is, after surgery, one of the little things that we do is we provide food to our patients. I have a number of patients that travel from across the Northwest, anywhere from 3 to 7 or 8 hour drive to get here. And so they're away from a lot of their traditional support structure. So they're staying in a nice hotel here in the area. And then we arrange for someone, for a local caterer, to deliver them a home cooked meal after surgery. So they get good quality food. They're not going out to McDonald's. And that accomplishes a couple things. It provides social support, and it shows that we care about them as a person. And also, I mean, as a physician, nutrition is important, and we have never paid enough attention to that in the traditional medical world. And because we're not having to bill insurance for everything that we do to get reimbursed, we're able to take on that little bit of extra work to make sure that the patient has some really good quality food, a steak dinner or or fish tacos or something
Sure.
nice to eat after surgery. And that really makes a difference in terms of how patients feel and how they recover afterwards.
Wow. Can you imagine trying to do that through an insurance model?
I can't remember what the CPT code for that is.
Oh my goodness. So, okay. So obviously the experience, if you want to call it that, was a top priority
Mhm.
for you. You wanted the patient to have a particular experience, which I guess from a, if we were to think about it from a business standpoint, that's one of your big differentiators, right? Is the
Mhm.
overall experience, not just one particular piece here or there. It's all these different pieces and how they fit together.
Right.
So how did you decide that those were the factors that you were going to include to the exclusion of other things that maybe you were doing before that you said, oh well, we don't need to do that.
A lot of it came down to just putting the patient at the center. So the with the patient being the decision maker and the buyer, the focus is solely on making sure the patient has a good experience and that their needs and questions are addressed. We do things like we use Spruce, which is a communication tool, HIPAA compliant and all that, but the key thing is it's easily accessible for the patient. So the patient can text us, call us, or use secure messaging anytime to ask questions before or after surgery. So they've got, in the traditional insurance system, if the patient has questions before surgery, usually you want them to come back to the office that you can bill for another preoperative visit. And work things up. But with the direct care world, you're not billing additional for every time that you interact with the patient. So the focus is on making sure that the patient gets their questions answered in a quick and efficient manner. So we use tools like that to make sure that the patient is at the center and has an excellent experience. And to answer your question a little bit more, it's just been a process of discovery as we go along. We run into different things, and that the question is always, how do we make sure that the patient has the best possible experience, that we really serve the patient well here?
Sure. So how is the structure of your practice different from an insurance based practice? And I'll get a little more specific about that. As an example, I have a colleague here in town who has an insurance based practice. He's a solo surgeon and he's got 11 billers and coders in his office. In addition to however many other administrative people, things like that. What are the differences? Like, because I can imagine that some of our listeners are like, well, this all sounds great. You make things affordable, but how do you actually keep the lights on? How do you make money? Charging less money.
Yeah, a lot of the overhead is different, and we're able to focus on paying the physician and the people providing the care, direct medical care, a lot more. Basically, what our office looks like is there's myself and my business partner who helps run the business side of things. And then we basically have one nurse who handles a lot of the patient care coordination. They do answer a lot of the phone calls, setting things up with the patient, coordinating, making sure all the documents are moving, all of that. And then I have our office manager who handles all the billing paperwork and stuff like that. But basically, it's just the two of them handling stuff because there's relatively little paperwork that we have to do. I use a Word document to write my notes and save them on a secure cloud drive. So I'm not paying for an EMR. The billing software is a PDF that we fill with the patient's name and the total, and then we send them a QuickBooks invoice. So we're paying relatively little for the software costs that add up to quite a bit for a traditional insurance company. And then the paperwork is pretty streamlined because, again, all that we care about is making things clear to the patient and clear to our partners so they know exactly what they're getting paid and the patient knows exactly what they're paying and what it's for. And when we streamline things like that, it just takes fewer people and less paperwork to get the same thing done.
Sure. So I'm glad you brought up the EMR. When Dan Paul in he's in Colorado
Colorado,
Springs.
yeah.
Yeah, and he argues pretty vehemently that EMRs these days are basically just billing machines, and the only reason there's any clinical input into them is because they need some of that in order to bill better.
hmm
Talk about the advantages of direct care and why an EMR isn't necessary in your practice.
Yeah, it's true. EMRs exist for billing and for the business side. They're not clinical tools. The really what you need for good clinical care is you need to be able to document what you've done. So if you or somebody else ever needs to go back and understand what's happened to the patient previously, they can understand that relatively easily. So you need a way to clearly document that, and then you need to be able to communicate with other people taking care of the patient. So when I tell the surgery center this patient needs their gallbladder removed, the surgery center needs to know what their medical history is and allergies and things like that. So I need a clear and simple way to communicate that to the surgery center. But that's basically all that you need. Paper charts are one way to do that. Honestly, paper charts are a little bit outdated. We don't live in a paper world anymore. But you can do that electronically without committing to a big electronic medical record. So I have a Word document. Other people will use Google Drive documents or things like that. But basically, I have a simple template that lists the relevant medical history that we were taught to collect in medical school. I write that down and save it, and then I can send a PDF of that over a secure email. I mean, we use Google email, which is encrypted and secure. And so I can email that document to them. They can clearly read it, unlike a faxed document, which everybody else uses, where you get all these black spots all over it and you can't read the fax. It's the 21st century, people. Come on. So that needs the ability to clearly record for myself and other people, and then easily communicate it. And that's basically all that we need from a electronic record, or from a health record, is good records and easy communication.
Sure. Tell me about your thoughts on CPT codes and direct care.
Yeah, it's a two-edged sword. CPT codes are a useful tool. Basically, it's a system originally put together by the American Medical Association that just describes in exhaustive detail most of what we do in medicine today. In some cases, it's very accurate. For hernias, there's a different code for an abdominal hernia or an inguinal hernia. For the first time a hernia is repaired, or a recurrent hernia, whether the hernia is just there or it's incarcerated. And it's tiered by size. So you have abdominal hernias less than 3 centimeters, 3 to 10 centimeters, over 10 centimeters. So it's this really useful taxonomy that describes most of what we do in a high level of detail. There's some weaknesses because it doesn't describe everything. There's some procedures that just don't fit well into that taxonomy, and there's some times where the taxonomy is driven more by lobbying. Some things with bunion repair, for example, there's codes that exist simply because a device manufacturer lobbied effectively to get a new code created to describe their products that people could get paid more for using their product. So there's things like that. Ultimately, it's a system designed by corporate medicine and endorsed by CMS, by Medicare. And so in a way, you're participating in that system by using it. I would love to see an alternative way to describe procedures, but the CPT codes are very familiar to a lot of the medical system, and people understand what you're referring to when you say I'm 46758 or whatever. That means something to most of the medical system. And the other big value is there's been a fair amount of work put into describing the relative value of those different codes. So a gallbladder is described as being roughly the same amount of work as an appendectomy, or a third of the work of a hip replacement. There's these different value systems that have been assigned to that. And again, there's some glaring deficiencies with that system, but there's also some value in the way that it's been put together. So it's a useful starting point. We don't want to be tied too closely to that, and I can easily see a future where we've developed a different taxonomy or a different way of describing the bundles that are provided in a way that's a little bit simpler, easier for patients to understand, and also just better reflects what we actually do clinically.
Sure. So I'm glad you touched on the future. So one of the last questions I want to ask you: in an ideal world, if you were king and you could fix the healthcare system, what would that look like? If you want to just focus on surgery, we could do that. If you have thoughts on the bigger picture, I'd love to hear that too.
Yeah. Just a couple ideas off the top of my head. Universal HSAs, where patients are able to direct their funds more effectively, would be a great start. Um, Less regulation and more options for people to start and run sharing programs would provide more options for patients to be self-pay or cash pay shoppers. Trying to think of something more specific with surgery. I guess the one other really big thing that I'd love to see is ways for physicians to come straight out of training and get into the direct care world. Most physicians, when they come out, are saddled with a lot of debt, and hospitals and corporations offer the golden handcuffs of high, steady pay while you're stuck in the insurance system. So I'd love to see either programs developed to help pay the costs for physicians who want to go into the direct care world to defray their educational expenses, or just a system to develop where those physicians that want to can get out without taking a huge financial hit, because they're not getting those signing bonuses and the guaranteed salaries from the hospitals.
Sure. So I think, at least on one of those fronts, we've started to see some progress. I know NYU was the first med school in the country to no longer charge tuition because they managed to get enough donations to cover the cost of tuition. Albert Einstein, I know, recently did something similar. And as I understand it, I think there might be 4 or 5 medical schools now in the United States which have similar programs, so that debt doesn't have to drive decisions about specialty and practice model.
Yeah. I mean, it's a little bit of a shell game because medical education does cost something. There's a real cost to that. But at the same time, saddling the physicians with hundreds of thousands of dollars of debt isn't the best way to do that. So whether it's tuition-free medical schools or scholarship funds put together by the direct care world to pay for scholarships for physicians that are going to pursue that, there's options that are developing. There's some businesses too that help with the startup costs for people going into direct primary care currently, and I'd love to see that developing for the surgery world as well.
Sure, that'd be awesome. So 2 last questions. The same 2 questions I ask every one of our guests. Number 1, what is, again, keeping in mind that our primary audience here is medical students, residents, fellows, people who are fresh out of training. What do you want them to know, particularly as it pertains to direct care, that you wish you had known when you were in their shoes?
The biggest thing is there's a viable alternative, and it's a thriving and rapidly growing marketplace. The direct primary care market has grown by 30% for probably the last decade, which is explosive growth for any business. And the direct surgery care world is rapidly expanding. There's a lot of patients who want this, a lot of businesses who want this for their employees, and there's a lot of physicians who are making it work. So it's hard in medical training because you never see this side of medicine. You're in large university systems, you train in large hospital systems where basically everything is driven by the insurance model, and you're lucky if you even hear if you're listening to this podcast, you're already way ahead of the rest of the world, because you know that there is an option. And that's the first big step, is even realizing that there is something other than the system that we all train in.
Sure. And then final question, how do people find you?
Veritas?
Yeah.
We're at veritassurgery.com, Veritas. All our prices are listed on there. There's a quick and easy way to contact us. And we're always eager to talk to anybody, help you look at your options and figure out what makes the most financial and clinical sense for your case.
Awesome. And if we have a medical student or a resident that's interested in learning more about what you do and how to do it and whether or not they might want to do it themselves, is that the best way for them to reach you also?
Absolutely, yeah. I get all of those emails from the website as well. I'm always happy to talk to medical students or residents who are interested in learning more about the options here. And someday I'd love to start having trainees doing rotations here so they get a taste of direct care and general surgery out in the real world.
That'll be awesome. Any other last thoughts that you have before we finish up here?
That's it.
All right. Well, thanks for joining us. It was awesome having you on our show, Dr. Abraham, and talking about direct surgical care is something that, as you know, excites me a lot. The Free Market Medical Association is growing by leaps and bounds across the country, and it sounds like it's having quite an impact out there in your part of the world. Everybody, that's watching this show, if you liked what you heard today, and you want to hear more, the number one, I would ask you to subscribe and on whichever platform you're listening to this on, and then tell a friend. Don't keep it a secret. There's some great stuff going on, and we want more people to know about it. This is direct care is the future, and it's the revolution, and you can be that revolution. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.